Hi guys, good evening. Hi Liaquat, good evening. Salam alaikum. Welcome. Yeah, okay. So, continuing on the same series of trauma. Yesterday we spoke about the skull injury. We'll dig deep in today. आज हम बात करेंगे with respect to the traumatic head injuries. ठीक है? So, without wasting any further time, let's kickstart the discussion. Again, if you have any questions, any queries, do ask. If you have anything that you want to tell, do let us know. There's no issues at all. Brain hemorrhage. Liaquat, today we'll be talking about traumatic brain injuries. इसमें we will be covering a part of hemorrhages, but not the extensive part. उसके लिए we have another series. In the neurosurgery part, we'll talk about all the hemorrhages also. For example, subarachnoid hemorrhages that you have the aneurysmal hemorrhages. All that we'll deal in there. But आज के लिए we'll try to talk about it in the context of trauma only. ठीक है? चलो. So let's dig in with the traumatic brain injury. So when you talk about a traumatic brain injury, say it's a patient who has undergone a road traffic accident, might have an injury to the head, but that head injury does not translate into a brain injury, right? It could have only a minor aberration, it could have a laceration, or it could have skull fractures. But if it has a deeper impact, if it hits the brain, then the problem becomes even more difficult. So today we'll be talking about traumatic brain injuries. So in order to understand the whole concept of the traumatic brain injuries, I'll be dividing them into two different parts. One is your primary brain injury, another one is your secondary brain injury. Now, what is this primary brain injury? What is the secondary brain injury? A primary brain injury is the injury to the brain. It is injury to the brain due to impact from trauma. Due to impact from trauma. It's a direct injury to the brain. So when I say a primary brain injury, it is a direct injury to the brain, and here the brain is getting injured or damaged because of the impact from the trauma. Now, what is your secondary brain injury? The secondary brain injury is not a direct injury, right? So it is something that is in response to a primary brain injury. What do you mean by this? It is injury to the brain. It is injury to the brain. It is injury to the brain due to increased intracranial pressure as a result of primary brain injury. As a result of primary brain injury, right? So it is the injury to the brain due to increased intracranial pressure, and that increased intracranial pressure is because of the primary brain injury. So trauma, which is causing injury, that injury will cause inflammation, and that inflammation will cause edema, and that edema in the brain will cause increase in intracranial pressure, and that will further add on worsening the injury. So that increase in intracranial pressure will further worsen the injury, and that further worsening of the injury is what we call it as secondary brain injury, right? So what is a primary brain injury? What is a secondary brain injury? The concept has to be quite clear and simple and crisp. A primary brain injury is the injury to the brain due to the impact from trauma. The secondary brain injury is the injury to the brain due to and raised intracranial pressure as a result of primary brain injury. As a result of primary brain injury as well, right? So that's the basic difference between a primary and a secondary brain injury. Ghansham, we do have the lectures on medicine taken by Dr. Santosh Patil. Sir covers extensively about Harrison, so you can talk about, you can just search Harrison's in the YouTube, you'll get Santosh's videos. It's also on a daily basis on an hourly lecture. It's also on a clinical medicine. Okay, so come back to our trauma chapter, right? So now we will be discussing about primary, then we'll move into secondary. So in the primary brain injury, I will be discussing three predominant injuries that we'll be dealing with. Number one, I'll be talking about something which is transient and short-lived. It is called as the concussion injury. It is a concussion injury to the brain. Another one which I would never want to see on my patient's case file, that is your diffuse axonal injury. This is your diffuse axonal injury. And the last one is going to be the intracranial hemorrhage. It is the intracranial hemorrhage. right? So we'll be discussing into three predominant headings of the primary brain injury. We have something called as the concussion injury, you have the diffuse axonal injury, and the intracranial hemorrhage. So when it comes down to the concussion injury, what is a concussion injury? It is a transient state of confusion. Concussion injury, it is temporary, that is a transient. It is a transient state of confusion. It is a transient state of confusion. Usually it is a reversible injury. It is a reversible injury, so there is no structural damage that you will see. And in fact, whenever you do an NCCT in a concussion injury, it does not give you any pathological or any findings that can cause or points towards a diagnosis. So presence of a normal NCCT with a transient state of confusion gives you a diagnosis of concussion injury. So that's the most common givenly diagnosis if the CT is normal and patient still emits signs of confusion after a head injury, and that is why the NICE guideline says admit the patient, observe for next 24 hours. So you have a transient state of confusion, it is a reversible state of injury, the NCCT remains normal, and here the management is going to be only the best supportive care. Here the management will be of best supportive care. Next comes one of the most important one, that is your diffuse axonal injury. Now this diffuse axonal injury is quite important as well as interesting to know how it occurs. Now diffuse axonal injury is defined as a complete disruption. There is this complete disruption of axons. This complete disruption of axons between the central white matter and the peripheral gray matter. Between the central white matter and the peripheral gray matter. So when you look at the entire component of the brain per se, you will see that this happens to be the flux cerebri, this happens to be the cerebellum, this is the tentorial plate, this is the cerebellum, this is the brainstem, right? So we have the same thing. This is the tentorial plate that you have, this is the cerebellum, and this is the brainstem that you have. Now you will see these are the ventricles which are present across here. This is going to be in this particular state. As we all know, right in the periphery you have the gray matter, so this is how the gray matter is depicted, and right in the center you have the white matter, which I'm not going to give you anything specific about it, right? So this is the central, the peripheral gray matter and the central white matter that you have. If you zoom in, you will see between these two, you have these axons which are running, right? So just for the sake of demarcation, just to tell you that this is the white matter, this is the gray matter. Let's say this is the white matter component that is present. Right? Between the white matter and the gray matter, you see these axons are transmitting the signals, or I can say the neural pathway is designed between the white matter and the gray matter. Now the diffuse axonal injury occurs whenever there is a sudden decelerating injury. Now what is a sudden decelerating injury is, in a road traffic accident, you would see, like, let's say a patient is driving a car. Now as he's driving a car and let's say he was intoxicated or drunk, and he is literally driving fast and he rams the car into a wall. So what is going to happen? The car is going to go hit, bang, and as it hits, bang, it suddenly stops. The head goes and hits onto the dashboard, and then the head suddenly comes to a standstill. So what is going to happen? There is a sudden decelerating injury. So the white matter and the gray matter will have a relative motion that is there. Now you need to understand the white matter is fixed, the gray matter is relatively mobile. So what is going to happen? In this sudden decelerating injury, the gray matter goes front and then comes back. Now imagine this way. This is the white matter, this is the axons, and this is the gray matter that is there. Now as there is a sudden decelerating injury, the gray matter goes front and back. So the white matter remains fixed, the gray matter moves. Now as it's like a whiplash, it goes front and back. So what is going to happen? This axon, it is going to break away, right? So this sudden decelerating injury is now going to cause the disruption of these axons. So you will notice that this injury is going to cause the damage in this junction, that is the axons which are present between the white matter and the gray matter gets completely disrupted. Now, when there's a disruption of the the axons between the white matter and the gray matter, what is going to happen here? The patient is now going to present to you in casualty with coma. Now, post-trauma, when the patient has developed coma, that means the patient is non-responsive, the GCS is 3 by 15, I would immediately take the patient for NCCT of the head. And for my surprise, it comes out to be normal, right? Now, in fact, this is one of the very early points that you need to understand, that on a NCCT in a diffuse axonal injury, you will get a normal finding. So what will you do immediately? I will take the patient immediately for an MRI as well, just to confirm it. Again, I'm telling you, diffuse axonal injury is purely a pathological diagnosis. So in a post-mortem report, when you do a brain section, then you will know it's a diffuse axonal injury. But on a radiological basis, it's a very feeble signs that you can pick here and there, especially when you're doing an MRI. In an MRI, there will be presence of a punctate hemorrhage. There will be presence of a punctate hemorrhage. Presence of a punctate hemorrhage between the white matter and the gray matter. Between the white matter and the gray matter. Between the white matter and the gray matter, and that indicates the patient is having a diffuse axonal injury. Remember, diffuse axonal injury, it is associated with very poor prognosis. There is hardly anything that you can do for the patient. Most of them land up in a vegetative state and end up donating their organs, so hence saving the further lives by sacrificing their own, right? So this condition per se is not a good one to have on your patients, because the prognosis is really, really poor. The prognosis is really, really poor, right? Now, if I am an examiner and I want to test, your core knowledge, I mean, like how intelligent you are. So I can ask you, it's usually a resident level question that I would ask you, that on a CT, I'm saying it is normal, but sometimes you might find few findings which are suggestive of diffuse axonal injury. Now, what are those ones, right? There will be presence of hemorrhagic foci. There will be presence of hemorrhagic foci. Now, where would you see this hemorrhagic foci? Number one, you can find this hemorrhagic foci in the corpus callosum. On the corpus callosum and on the dorsolateral rostral of the brainstem. On the dorsolateral rostral of the brainstem. So this is that extra edge point that, all the cool kids or the intelligent kids would know, that if there is presence of a diffuse axonal injury, there are findings on CT that might point towards diffuse axonal injury. There are two finds that you have presence of a hemorrhagic foci at the corpus callosum as well as the dorsolateral rostral of the brainstem. Okay. Now coming to the most important part, that is your intracranial hemorrhage. Majority of our lecture that we'll be talking about today will be concentrated on the intracranial hemorrhage. Now, intracranial hemorrhage is the hemorrhage that you will see within the brain parenchyma or around the brain parenchyma, to be precise. Now, in order to understand this, let's take a quick component here. Take this as a representation of the brain, right? Let's say this happens to be representation of the brain. Right immediately, which is going to be present covering the brain, is going to be your pia mater. In fact, the pia mater is almost inseparable from the brainstem. So the innermost layer that you will see is going to be the pia mater. Surrounding the pia mater, you have the arachnoid membrane. So this happens to be the arachnoid membrane. Surrounding the arachnoid membrane, you have the dura, which is here. And surrounding the dura, surrounding the dura, you have the skull bone. Surrounding the dura, you have the skull bone, which is here. Right, so just for the sake of understanding, if I have to continue across here, so this is a skull bone which is going to be present across here, right? So this is the representation that you'll see from inside out. If I just give you a quick recap of what we spoke, the innermost is going to be brain parenchyma, and then this is what we call it as the pia mater. This is your arachnoid membrane. This happens to be the arachnoid membrane. The outermost is going to be the dura of the skull, and dura of the brain, and this is the skull bone, which is present on the outer surface. Now, where do you have the CSF? It is freely floating somewhere across here. So if I highlight that, where is the CSF? You will notice the CSF is present in the subarachnoid space. So this is where the cerebrospinal fluid is going to flow. It is in the subarachnoid space that you will find the CSF. So you'll notice that this happens to be the cerebrospinal fluid. This is your CSF, right? So we have marked all the important structures. The innermost is parenchyma, then you have the pia mater, the arachnoid membrane, the dura, and the skull bone. In between, that is between the pia mater and arachnoid, you have the subarachnoid space, and within the subarachnoid space, you have the cerebrospinal fluid that is flowing. Now, where are the bleeds which are possible? The bleed can occur here, which is going to be an intraparenchymal hemorrhage. Next bleed you can see here, which is going to be your subarachnoid hemorrhage. This is going to be the subarachnoid hemorrhage. You'll see another bleed that can occur here, which is your subdural hemorrhage. Now, what is interesting to know is there are two meningeal layers which are adherent to two different surfaces. The pia mater is adherent to brain. It is inseparable from the brain. The next one is the dura mater. You will see the dura of the skull is adherent to the skull bone. The dura is quite adherent. I'm not saying it is plastered, but is quite adherent to that of the skull bone, right? So dura is going to be quite adherent to that of the skull bone, and that is why the dural hemorrhages, they become very confined. They're not as extensive. For example, the subdural hemorrhage, when it develops, it spreads out through entire, the entire component of the brain, or it occupies a wider surface area, to be honest. Now, on the other hand, when you have an extradural hemorrhage, the extradural hemorrhage will only be able to occupy the space from where it is going to develop. For example, if the hemorrhage occurs here, it will only be able to take this much amount of space. The reason being that the adhesions are so strong that the hemorrhage cannot expand in its own capacity. Second, it will only push the dura down. So you'll see the dura is being compressed down. Now, as the dura is being compressed down, you see that this area of the brain will have some amount of impact force, right? Now, this impact force concept is important. We'll discuss the impact force concept is important. We'll discuss as we move, but this is how the dura is getting compressed. This compressive force of the dura is now being transmitted onto your arachnoid membrane, and from there it is being also transmitted to that of the pia mater, which is closely adherent to the skull bone, right? So all this force that is created, all this force, you can see the force is now being transmitted downwards. Now, why would a force transmit downwards? Because see, on the upper side you have the skull bone which cannot nudge. Skull bone says, get lost, I'm not going to go anywhere. So whatever hemorrhage or the hematoma that develops, it is only going to expand towards the brain, not away from the brain. Now, why it is expanding towards the brain? Because the skull bone cannot be extended. So it says, I am strong, I am rigid, I'm going to stay there. So the entire force will now start to compress onto the brain. And as we go further, you will also know that this compressive force can result in brain herniation. and that is also a very important concept. We'll talk about a beautiful concept called as the Monroe-Kelly doctrine as well, which tells you about the brain herniation as the pressure increases. But for now, you need to understand that whenever the hemorrhage, that is extradural hemorrhage, is going to occur, the pressure mounts more onto the cranium or onto the brain when compared to the skull bone that is going to be there. So based upon this, if you highlight everything that we have just discussed it, the innermost is what we call it as the intraparenchymal hemorrhage. It is the intraparenchymal hemorrhage. Then you have the one that is present between the arachnoid membrane and the pia mater. It is your subarachnoid hemorrhage. The one that is present between the dura and the arachnoid membrane is your subdural hemorrhage. And one that is present between the dura and the skull bone, this is your extradural hemorrhage, right? So three common types of hemorrhages that we have just listed. The first one is EDH. EDH is your extradural hemorrhage. It is the extradural hemorrhage. SDH is going to be the subdural hemorrhage. It is the subdural hemorrhage. And SAH is your subarachnoid hemorrhage. It is your subarachnoid hemorrhage. Right? So we look at a quick succession here. Right? So we talk about traumatic brain injuries. The traumatic brain injuries can be divided into these many components. The first one is your extradural hemorrhage. It is a collection of blood between the dura and the skull bone. Then you have the subdural hemorrhage. The subdural hemorrhage is a collection of blood between the dura and the arachnoid membrane. Then you have the subarachnoid membrane hemorrhage. The subarachnoid hemorrhage is a collection of blood between the arachnoid membrane and the pia mater, and one that is present inside the brain parenchyma is called as the intraparenchymal hemorrhage. Now the question is, in trauma, what is the most common type of hemorrhage that you will see? Remember, the most common traumatic hemorrhage overall, in terms of incidence, the most common traumatic hemorrhage that you will see more often than not is going to be your intraparenchymal hemorrhage. It is the intraparenchymal hemorrhage. Hi, Siraj Alam. Good evening. Okay. So these are the various types of your primary brain injuries. So you have the concussion, diffuse axonal injury, and the intraparenchymal hemorrhage. Now our job is to deal with all of them. I'll be starting with the most basic one to compare with. That is going to be your extradural hemorrhage and the subdural hemorrhage. So we'll talk about a comparative discussion between the extradural hemorrhage and the subdural hemorrhage. Clear? Chalo. Now, when you talk about an extradural hemorrhage by definition, it is the collection of blood. It is the collection of blood between the dura and the skull bone. Between the dura and the skull bone, as simple as that. On the other hand, when it says subdural hemorrhage, the subdural hemorrhage is defined as it is the collection of blood. It is a collection of blood between the dura and the arachnoid membrane. Between the dura and the arachnoid membrane. So based upon where the blood is getting collected and how it is forming an hematoma, how is imparting pressure, you have the extradural and the subdural hemorrhage that is present. Right? Now, what is the mode of injury when it comes down to both of them? Remember, when it comes down to the extradural hemorrhage, it is usually associated with a road traffic accident. It is usually associated with a road traffic accident, telling you that it is a high velocity or a intensified injury, and this is usually seen secondary to a temporal fracture. Now, where you have the squamous bone, or I can say the three bony components where they combine together, that is your pterion, right? So it is the temporal bone fractures that you will usually, or temporal fractures, which is usually associated with extradural hemorrhage. Subdural hemorrhage, it is usually seen in elderly patients. It is usually seen in elderly patients with history of, number one, significant fall, history of significant fall, hit or blow to the head. So elderly patients with a history of significant fall or hit or blow to the head usually may present to you with a subdural hemorrhage, right? Now, when you talk about what is the most common source of bleeding, now you can see that there is a vessel that is going to run in a perpendicular direction at the level of the temporal bone in passing to the pterion. That is a middle meningeal artery. So whenever the fracture occurs here, the most likely vessel that can give away or rupture is your middle meningeal artery. So the most common source of bleeding here, is going to be the middle meningeal artery. It is going to be the middle meningeal artery, right? On the other hand, when it comes down to the subdural hemorrhage, the most common source of bleeding, it is going to be because of the rupture of the cortical bridging veins. It is going to be the cortical bridging veins, right? So you have two important sources of bleeding. See, forget about what names I have written. The most important here is, in one of them, the source of bleeding is an artery. The source of bleeding is going to be artery. The other one, the source of bleeding is going to be vein. Another very interesting thing or important thing, I have discussed it previously also, that whenever there's an extradural hemorrhage, the hematoma, one, it is an arterial bleed. Second, as it expands, it will expand towards the brain, not towards the skull. Another thing is, it is going to be confined. It is not going to have a wider surface area. It will be usually confined to an area, and then it starts exerting pressure downwards. Now, why it is confined to that particular area, why it is not having a wider surface area of, let's say if there's a good space between the dura and the skull bone, the blood should occupy the entire surface area of the brain. No, it does not. It only occupies a certain area. Why is that? Because there are dense adhesions, or let's say the dense adhesions between the dura and the skull bone. So when the hematoma forms, the hematoma becomes like this. Why? Because there are these two are adhesions, right? So hematoma is only going to extend. See, this like it will only going to extend like this. The hematoma forms, it extends like this, and the pressure is going to be exerted downwards. The pressure will be exerted downwards. Now this, obviously, when the blood will as it continues to bleed more and more, you will see this will also become wider and become more longer like this. So initially it is smaller, it becomes bigger. It can become like this also, right? So the extension of the hematoma is not only going to be downwards, it will be lateral also, but the lateral spread is much lesser, and the force exerted downwards is going to be much more severe, right? So this is the reason why extradural hemorrhages are surgical emergencies, because as they extend, they don't occupy the surface area first. See, if they occupy the surface area, the pressure on the brain would be less relatively. Imagine if it was extending like this. So obviously the impact on the brain is lesser as it extends, but only this much area is extending. So this dependency or this pressure exerted on the brain, or the parenchyma of the brain is going to be quite severe. Hence, it will become more symptomatic. I hope I made sense out of it. This is one of the very important concepts why extradural hemorrhages are very important, and they are going to be, detrimental factor in terms of morbidity as well as mortality. Okay? Now, when you look at the clinical features, all these hemorrhages or hematomas, what are they doing? They are occupying some space in the brain, or they are occupying some space within the cranial cavity. The problem with the cranial cavity is it's a confined cavity. It says, I do not have enough space, I cannot accommodate anyone else, get lost. Whatever is there, it is there. I will not take anything extra. Even a small tumor, it increases the pressure because it's occupying space. In brain, it's all about space occupying component. Now, this blood that is going to come here is occupying the space within the cranial cavity, hence causing raised intracranial pressure. Now, as any of these lesions are going to do, they will present to you with signs and symptoms of raised intracranial pressure. So you'll see the raised ICT or an intracranial tension or intracranial pressure is elevated. Here in the subdural hemorrhage also, there will be signs and symptoms of raised intracranial pressure. There will be signs and symptoms of raised intracranial pressure. So what is the difference? How do you know whether the patient is coming with an extradural or subdural hemorrhage? The only difference that you need to know across here, that whenever you have signs and symptoms of raised intracranial pressure in an extradural hemorrhage, these will present to you with sudden, severe onset of symptoms. these will present to you with sudden severe onset of symptoms. On the other hand, when there is a subdural hemorrhage, they will present to you with gradual and slow progressive symptoms. They present to you gradual and slow progressive symptoms. They'll present to you gradual and slow progressive symptoms. As simple as that. Now, what are the features that you're expecting? Now, when the raised intracranial pressure is there, the patient is going to present to you with severe headache. They'll present to you with severe headache. Now, they will have vomiting. They will not have nausea. So, this is what we call it as a projectile vomiting. This is what we call it as the projectile vomiting. So, all vomiting that are induced by brains are usually projectile in nature. So what is a projectile? What is a non-projectile vomiting? Now the definition of projectile vomiting is if a patient is having vomiting without having nausea, it is called as projectile. If a patient has nausea and then vomits, it is non-projectile. So definition of non-projectile vomiting is if a patient's vomiting is preceded by nausea, it is non-projectile. If a vomiting is not preceded by nausea, it is called as projectile vomiting. Now, along with that, what else you will see? There will be blurring of vision. There will be blurring of vision. And more importantly, there will be post-traumatic seizures. Now, all these are going to be characteristic features to tell you that the patient is having a raised intracranial pressure. Along with that, when you examine it, right, you will see ipsilateral dilated pupil and contralateral hemiparesis. So same-sided pupil will be dilated because of raised intracranial pressure, and contralateral weakness will be say hemiparesis, or let's say weakness is going to be present. But what is interesting in your extradural hemorrhage is there is presence of something called as the lucid interval. It is called as a lucid interval, right? So what is this lucid interval? The classical description of this lucid interval, it is described as the period of consciousness. It is the period of consciousness between two unconscious episodes. Between two unconscious episodes. Now, if I have to put this in a very, descriptive manner, lucid interval basically tells you that there is an episode of rebleed. And a rebleed indicates it's an arterial bleed because high pressure bleeds can evolve and occur again and again until you don't have a definitive component. Venous bleeds, on the other hand, when it gets compressed, they stop. Arterial bleeds, they don't. You need to go and address them. You need to ligate the vessel which is detrimental or causing that particular leak. So a lucid interval is described as a period of consciousness between two unconscious episodes. Now what happens is as soon as the patient hits a trauma, right? The head injury, there's middle meningeal artery burst, massive hematoma, exerted pressure on the brain, patient goes unconscious. So initially you will see the patient is having a state of unconsciousness. Now as the blood starts to pull in more, the hematoma forms bigger. As the hematoma becomes bigger and bigger, it will start exerting pressure on the source itself, right? It will that hematoma that is developed will exert pressure on the vessel from where the bleeding is occurring. Now that vessel is going to get occluded under this force, and this is what we call it as a tamponade effect. Now because of that, the bleeding stops. Once the bleeding stops, patient regains consciousness. Okay, I'm like all cool, okay, no problem. He starts standing up, starts moving around. Now he's going to move his head here and there. Now obviously when he moves his head, there's a possibility the hematoma can dislodge. Now when the hematoma dislodges, the pressure on this vessel goes away. If the pressure goes away, it bleeds again. If it bleeds again, the pressure increases again. Raised intracranial pressure will now put down the patient again. Hence the patient will become unconscious. And that is how you will have your lucid interval. So lucid interval is trying to tell you it is a high pressured bleeding vessel. As simple as that. I hope you got that concept. On the other hand, when you come down to your subdural hemorrhage, you will have all these features. You will have headache, patient will have vomiting, there will be presence of blurring of vision, Usually the post-traumatic seizures are not there because they're seen with rapid increase in pressure. Yes, you will have same-sided dilated pupil, there'll be contralateral weakness, but they will not have any lucid interval. So two things that differentiate between extradural and the subdural hemorrhages is right in front of you. Any question, anytime they ask you in your viva, in your exams, this is what you need to remember. Again, don't mug it up. It's all about logic. It's all about concept. You know, raise intracranial pressure, all these will be there. The only difference that you need to know, this will be sudden, this will be gradual. That's it. उससे ज़्यादा कुछ और ज़रूरी नहीं है. ठीक है. Now, once you have a patient who's been brought to you with all these features, yes, I would want to know. Obviously, the investigation that you will do for all traumatic head injuries is going to be NCCT of the head. You will do an NCCT of the head. I'm not going to go into greater details about the NCCT head. That is for another day. But for now, you remember on an NCCT, you will see this. You see, this is the hemorrhage. Right? Now, this is the collection. Now, you can see if you look across, it is compressing the ventricles. There is the flax cerebri is shifting lightly. There is a midline shift as well. There are certain things that you need to understand. We'll talk about it later. For now, you remember when you do an NCCT head for a patient who is going to have an extradural hemorrhage, you will see a presence of biconvex opacity. The two surfaces which are convex, so it is a biconvex opacity, or also called as lenticular opacity, also referred to as the lenticular opacity on an NCCT head. Okay? Now, when it comes down to the other component, when you do an NCCT head in a subdural hemorrhage, now because a slow venous bleed, it will occupy more surface area, so obviously it tends to spread more. Now the evidence is right from here. You can see that it is occupying more area. So this is in terms of area when compared to the size, right? So the width of the hematoma is smaller, but the surface area is larger. Look at here. How much is surface area and how much is the width? It is confined to this much only, but it is extending more. As I told you, because of those dense adhesions. But compare this one here. So you have both the images here. You can see this one, it is occupying smaller area, but it is, you know, extending more into the parenchyma. Here it is occupying more surface area. Hence, it will have lesser impact on the brain parenchyma, lesser pressure symptoms when compared to that of the context. Now, when you see the NCCT brain here, this is what we call as, one is concave, another one is convex. It is called as the concavo-convex opacity. I hope it is justifiable, but I'll still give you the objective. See, one surface, this is your concave surface. This happens to be your convex surface, right? So one surface is concave. Another surface is convex. So it is your concavo-convex opacity, right? Apart from that, this is also called as a crescent opacity, also referred to as a crescent opacity. So concavo-convex opacity as well as your crescent opacity, right? Now, we're not going to go into greater details about the protocols of management, but remember, for an emergency management which will have a rapid component here, so here you would like to go ahead with burr hole surgery. Now, burr hole surgery, it is to create an emergency outlet to vent the hematoma out, right? So it is an emergency outlet in the temporal region. In the temporal region to evacuate hematoma. To evacuate hematoma. Now remember, whichever side you have dilated pupil, that side you will do a burr hole, as simple as that, right? If the pupil is dilated on the right side, you will do a right burr hole. If it is dilated on the left side, you will do a left burr hole. Okay? If it is weakening on the right side, the hole should be on the left side. If the weakening is on the left side, the hole should be on the right side, as simple as that. Okay? So this is in the emergency, but definitive, you have to take the patient for craniotomy. You have to take the patient for craniotomy, identify the vessel, ligate it, and then be done with it. And these are the managements you will do for your extradural hemorrhage. For a subdural hemorrhage, if it is a small subdural hemorrhage, which is not causing much of the symptoms, it is conservative. It is conservative. But if it is a large STH, rather than saying a large, it's if it is having more symptoms, especially if it is dilated pupil, non-responsive, with gradual increase in features of pressure, like weakness is increasing more, pupil is becoming non-reactive, patient is having headache which is not resolving. In any of those contexts, take the patient for craniotomy. Take the patient for craniotomy. Okay? So this is in response how you would manage both the components of your extradural as well as subdural hemorrhage. As well as extradural and the subdural hemorrhage. 1 second. The app. Yeah, okay. It is the extradural and the subdural hemorrhage, right? So this is how you're going to manage, right? So far, any questions, quick feedback? If you have no questions, we'll move on to the next part, that is your secondary brain injury. But this is the basic of your primary brain injury. So this is the concept that you should get in grip. You should understand, hope everything is good. I can see something. 1 second. Okay. Okay. Clear. Can you move on? Up for it, up for it. Can we move on? Quick feedback. Okay, chalo. So let's go on to the next topic, that is your secondary brain injury. Now there's a very beautiful concept behind it, right? Now secondary brain injury, as we have told you, it is an injury to the brain. Secondary brain injury is going to be defined as, so we'll take it here. So the secondary brain injury, it is injury to the brain. It is injury to the brain due to increased intracranial pressure as a result of primary brain injury. As a result of the primary brain injury, right? It is an injury to the brain due to a raised intracranial pressure as a result of the primary brain injury. As simple as that. Now, what can this primary brain injury does? It actually creates cerebral edema. And that cerebral edema is going to result in further increase in pressure. That cerebral edema is going to increase in further pressure. Uday Kiran, we will tell about the opacities. Don't worry about it. I've given you 2 examples here. We have a detailed discussion on how to decode CT brain in trauma. Okay? In that we'll talk about all the spectrums, but let's not go overbound here because this lecture is purely concentrated on traumatic head injuries. We'll stick to the plan. Okay? Now, so what is going to happen if there is increased intracranial pressure? We'll try to understand the basic concept behind it. In order to understand this concept, you need to understand something called a CPP, which is called as a cerebral perfusion pressure. Now, if you say what is a cerebral perfusion pressure, it is the pressure required to perfuse the brain. Cerebral perfusion pressure, it is the pressure required to perfuse the brain. It is the pressure required to perfuse the brain. Now the question is, how do you calculate the cerebral perfusion pressure? Now the cerebral perfusion pressure, that is CPP, it is calculated as mean arterial pressure minus intracranial pressure. CPP is calculated as the amount of pressure pumped by your vessel, that is aorta, that is the mean pressure, and subtracted by intracranial pressure, you will get the net pressure that is going to reach into the brain. Now, how do you look at in general sense, what is the normal CPP? Again, do not try to mug up the values. Now, how do you calculate the mean arterial pressure? I hope everybody knows it. The mean arterial pressure is a combination of 1/3 of the systolic blood pressure and 2/3 of your diastolic blood pressure. It is 1/3 systolic blood pressure and 2/3 is the diastolic blood pressure. So when you calculate the CPP, what is the normal mean arterial pressure that you have? I hope everybody knows the normal mean arterial pressure is anywhere between 90 to 110 millimeters of mercury. It is 90 to 110 millimeters of mercury. The normal CPP that you will see, it is going to be 5 to 15 millimeters of mercury. So normal intracranial pressure is going to be 515, mean arterial pressure is going to be 90 to 110. So that brings down to the value, what is the normal CPP value? The normal CPP value will be anywhere between 75 to 105 millimeters of mercury. It is going to be between 75 to 105 millimeters of mercury, right? So this is how you will calculate your cerebral perfusion pressure, right? Now there's a concept which is called as the minimum CPP required to perfuse the brain. So how much is the minimum CPP? How much is the minimum cerebral perfusion pressure required to perfuse the brain? So you do not confuse when I say minimum, that means this is the pressure. Below this, the brain will start experiencing hypoxia. As simple as that, right? If a pressure drops less than this minimum number, the patient will start developing hypoxia to the brain, and the most sensitive tissue in the entire body, which is very sensitive to hypoxia, it is brain. So neurons are the most sensitive to hypoxia, and the neuron ischemic time is 2 to 4 minutes. You don't want that to happen. You want your brain to be adequately perfused. So now when we say what is the minimum CPP required, the minimum CPP required should be more than or equal to 65 millimeters of mercury, right? In some textbook it is given as 60, so you can say as a range, if I talk about a single number, it is between 60 to 65 millimeters of mercury. Now to be very honest, it is going to be, we say 1 gram of brain tissue should get 55 ml per minute, right? That is the volume that is supposed to be delivered. To deliver that amount of volume, this is the pressure that is required, right? This is the basic concept you need to understand. Now, what will happen if there's a raised intracranial pressure and its impact? Now, to understand this, let's say we're talking about a cerebral perfusion pressure, which is calculated as the mean arterial pressure minus intracranial pressure. I just told you that the intracranial pressure is elevated. So there is increase in intracranial pressure. When there is increase in intracranial pressure, by the simple equation, I know that the cerebral perfusion pressure will drop, right? Whenever there's a raised intracranial pressure, obviously with this equation, you will see the cerebral perfusion pressure is going to decrease. And body says, I cannot let this happen, because if the CPP drops, the blood pressure which is required to reach to the brain will decrease. So brain will not get enough amount of blood. If brain does not receive enough amount of blood, it will go into hypoxia, hence causing the problem. Now, in order to avoid this, body says, I'm not going to let this happen. And remember, body is a great fighter. It won't give up so easily. And we ask body, how will you compensate? Body says, don't worry, I will increase the mean arterial pressure. And when I increase the mean arterial pressure, it is going to neutralize the decrease in CPP. Hence, the CPP is balanced. The intracranial pressure is increasing. The mean arterial pressure also increases. So, the CPP remains normal. So, the compensation occurs by increasing the mean arterial pressure. I said body, great. Right? So, how does this compensation works? Body says that in order to compensate for increased intracranial pressure, I am now planning to increase the mean arterial pressure. I said it's a great thought. But we know that the mean arterial pressure is a combination of 1/3 of the systolic blood pressure and 2/3 of the diastolic blood pressure. Now, out of these two, which one do you want to increase? Do you want to increase systolic or diastolic? See, diastolic is a recoil pressure that is generated by a systolic pressure. So, diastolic is a relative pressure, not an absolute pressure. So, obviously, logically, the answer would be that I would like to increase the systolic blood pressure. So, in order to increase the mean arterial pressure, the systolic blood pressure has to be increased. I said, great. Now, in order to increase the systolic blood pressure, the body has two options. So whenever you want to increase the pressure inside a vessel, either you have to decrease the lumen, that is cause a vasoconstriction, or increase the volume of blood into that vessel. Now when you think about these two options, as a body you have two options to increase the pressure, either decrease the size of the vessel or increase the volume. Now every time you think about this, the easiest option is to decrease the size of the vessel. It's easy thing to do, but remember, easy things do not yield results. You need to do the tough one, the difficult one to reach. Yes, you need to be smart, but at the same time, you also need, the smartness is to understand that which path will take you to the ultimate goal. The smartness is not just to think about shortcuts. No, don't be fooled by that. Now here body says I have two options. Either I can go ahead with vasoconstriction or increase the volume of blood, or increase the volume of blood in the blood vessel, or increase the volume of blood in the blood vessel. Now, whenever you do a vasoconstriction, yes, it will increase the pressure, but it also decreases the volume of blood reaching to the brain. I told you the minimum blood supply to the brain tissue. For every 1 gram, I need minimum 55 ml per minute. If you do a vasoconstriction, the volume of blood delivered to the brain will decrease. Hence, the hypoxia will not improve. Now, as the hypoxia is not going to improve, vasoconstriction is a bad option. I would like to go ahead by increasing the volume of blood in the blood vessel. Now the question is, how would you increase? We said body, okay, fine, we understood you want to increase the volume of blood. How would you increase it? Now body says it's very simple. You remember our guy, this is the left ventricle, right? Now the amount of blood available in the left ventricle just before the contraction. The amount of blood available in the left ventricle just before the contraction. This is popularly known as preload. This is popularly referred to as the preload, or also called as the end diastolic volume. At the same time, the amount of blood which is left behind. The amount of blood which is left behind after the contraction. The amount of blood which is left behind after the contraction is what we call it as afterload. Preload is the amount of blood available in left ventricle before contraction. Afterload is the amount of blood available in the left ventricle after contraction. So preload is before contraction, afterload is after contraction. So what is happening? In between, the blood is ejected out, right? And this is what we call it as the cardiac output. The cardiac output can be measured as preload minus afterload. Now we all know the blood pressure depends upon the volume of blood. So what is the blood pressure? It is the pressure exerted by the volume of the blood onto the lateral walls of the vessel. I repeat, the definition of blood pressure is the pressure exerted by the volume of the blood onto the lateral walls of the vessel. In order to increase the blood pressure, I have to increase the volume of the blood. How will I increase the volume of the blood? In order to increase the volume, that is, you have to increase the cardiac output. Now, in order to increase the cardiac output, I have to increase the preload. Now, in order to increase the preload, that means I need to fill the left ventricle for a longer duration of time so that more amount of blood can come into the left ventricle. Now, in order to increase the preload, what you have to do, you have to allow more amount of blood to come into left ventricle. So what will happen to the end diastolic filling time? Now the end diastolic filling time, it is the time taken by the left ventricle to fill. I want more amount of blood to be filled into the left ventricle. Obviously time taken to fill, that is going to increase. So what is going to happen? I am going to increase the end diastolic filling time. If the time taken to fill the left ventricle is going to increase, what is going to happen to the heart rate? What is going to happen to the heart rate? It is the rate at which the heart is going to contract. Obviously, time taken for the left ventricle to fill is becoming longer, so the contraction per minute will become less. Because let's say initially I was able to fill the left ventricle in one second. So in 1 minute I was able to beat for 60 seconds, 60 times. Simple concept. If I'm able to fill the left ventricle in 1 second, in 1 minute it will be able to beat 60 times. Now I am increasing the diastolic filling time. That means the time taken for the left ventricle to fill from 1 second has become 2 seconds. That means for every time the left ventricle is to fill, it will take 2 seconds. So the contraction, obviously, if you are taking 2 seconds to fill and then contract, so the rate at which it is going to contract, it is going to be 30 beats per minute. So initially it was 60, now it is 30. So what has happened? The heart rate is going to decrease, right? So the heart rate is going to decrease. At the same time, what is going to happen to systolic blood pressure? Amount of blood which has been delivered. Obviously, the cardiac output is increasing. The volume of blood going into the aorta increases. Hence, the aortic pressure will increase. The systolic blood pressure will increase. Now, remember, raised intracranial pressure exerts pressure onto the cerebropontine angle, which also causes the pressure at the respiratory center. So, this patient will also experience a increase or decrease. That is irregular respiratory rate. Right, so when you look at this, you have a patient, decreased heart rate is what we call it as bradycardia. Increased systolic blood pressure is what we call it as hypertension. So you have a patient with bradycardia, you have a patient who is having bradycardia, hypertension, and irregular respiratory rate, and all these three put together is given a fancy name, and that is what we call it as the Cushing's triad. This is what we call it as the Cushing's triad. So don't try to mug up Cushing's triad. You need to understand that how the body is able to compensate fight in order to attain or achieve Cushing's triad. So basically, what is Cushing's triad trying to tell you at the end? The Cushing's triad is trying to tell you at the end that the patient is having raised intracranial pressure. As simple as that. ठीक है, तो इतना क्लैरिटी तो है कि भाई देखो पेशेंट को रेज्ड आईसीटी है, एंड रेज्ड आईसीटी, हाउ डू यू नो? सी, इट इज नॉट ओनली गोइंग टू बी स्पेसिफिक ट्रॉमा. Anywhere you have a raised ICT, patient is going to have Cushing's triad. I hope everybody now understands Cushing's triad. Clear? Quick feedback. Quick feedback. Clear? Can we move on? Okay. So once you have a patient with raised ICT, how would you like to manage? Now the first thing, if it is a severe increase, I would keep the patient in a propped up position. I will oxygenate. If patient deteriorates, I will intubate. Now once I intubate, now it is questionable whether to hyperventilate or not. Now hyperventilation is now in a questionable state. It is usually found that when you hyperventilate a patient, there's a carbon dioxide washout. The carbon dioxide washout will cause respiratory alkalosis. The respiratory alkalosis causes depression of the choroid plexus, which causes decrease in CSF production. And when the CSF production drops, the intracranial pressure will also decrease. That was the basic concept that we had, right? But now questionable. So intubate, no need for hyperventilation, but you have to keep the patient in a propped up position. You can start the patient on IV mannitol. Patient on IV mannitol to decrease the cerebral edema, right? So this is what you're looking in terms of management. And how do you know whether whatever you're doing is actually responding to the patient or not? Now, in order to monitor, the mean arterial pressure should be maintained between 80 to 90 millimeters of mercury, so that the CPP can be maintained at more than or equal to 60, right? So CPP should be maintained at more than 60 millimeters of mercury, because less than this will cause severe brain hypoxia. The intracranial pressure, which is usually 5 to 15 millimeters of mercury, you have to make sure that it is maintained less than 20 millimeters of mercury. Now sodium and potassium obviously has to be maintained at its normal component, that is 140 milliequivalents. And this has to be more than 4 milliequivalents, right? So milliequivalents are the millimoles per liter. Okay? So these are the target components that you have to make sure that you are able to achieve when you're managing the patient in your ICU, that neuro ICU, that is MAP of 80 to 90, ICT that is between less than 20, CPP should be maintained more than 60, sodium should be more than 140, potassium should be more than 4. If you're talking about, they can ask you about the partial pressure of oxygen, should be maintained at more than 11 kilopascals. It should be maintained more than 11 kilopascals. If you're able to achieve this, you will have a good prognosis for your patient, right? So this is all that you should know in the context of traumatic brain injuries, right? So with this, thank you so much for watching today. We'll continue tomorrow with the extension of the head injuries. Yes, tomorrow we'll be talking a small bit about the a higher component of the head injuries. Tomorrow I'll talk about what is the Monroe-Kelly doctrine. We'll talk about what are the brain herniations, what are their symptoms, and how, in the context, how would you like to manage about it. Okay? So with that, let's take a break today. We'll resume back tomorrow, same time, 9 to 10 p.m. On our YouTube. Just type BLS, you will get it. If you have any questions, any queries, you know where to reach out. You can always send your queries onto the Instagram, that is the surgery guy. It is by my name, that is your Dr. Sandeep Seeram Reddy. Any questions, anything, please post us here. So you have the both, it is for both Instagram as well as your Telegram. Okay? So both Insta and Telegram, you can reach down to the surgery guy, post your questions, queries, anything you want to ask, I'll be there. With that, thank you so much. Signing off for tonight. See you guys tomorrow. Bye. Good night. Take care.